Okay, this webinar is titled Hernias 101, Causes, Symptoms, Diagnosis, and Treatment. And our presenting provider is General Surgeon Joshua Payne. Dr. Payne sees patients at the Trinity Health IHM Medical Group General Surgery location in Livonia. Thanks for being here, Dr. Payne.
Yeah, of course. Thanks for having me. I'm just going to share my screen. Is that okay?
Absolutely. Go for it.
Does that look appropriate?
Looks great. Thank you.
Awesome. So thank you for the introduction. So like I said, I'm Joshua Payne. I'm one of the newer general surgeons here at Trinity Health Livonia. We're going to talk a little bit about hernias. So as some of you probably know, that's why you're here, there's many different types of hernias. The main ones we're going to talk about are involving the abdominal wall. However, there's also hiatal hernias, which I won't go too in depth. And I'll kind of cover the broad topic for today. So just a little bit about myself. There's a picture of myself there. I apologize, there's a window right in front of me, and it just happens to be that time of night where the sun is just right there. But anyway, I finished my training actually in the last couple of years. I'm a local guy. I grew up downriver, went to the University of Michigan for undergrad, and then, for better or worse, ended up at Ohio State for medical school. Spent some time down there, and then I came back to Michigan and did residency over in Pontiac at Trinity Health Oakland, where I completed my residency in general surgery. I then did well enough to get a fellowship for trauma and surgical critical care at Henry Ford Hospital, downtown Detroit, which I finished last year and then passed all of my boards. And now I've kind of decided to stay in the area and kind of get back to the community I grew up in. So thanks for everyone for coming. And like they had mentioned, I'll try to get to everyone's questions by the end, and hopefully I answer quite a number of them as we go through kind of the slides I prepared. So I just kind of want to keep this pretty basic, just that way it kind of hits a wider audience. So what's a hernia? So in essence, a hernia is generally when we have a hole in the abdominal wall or other tissue, and something else protrudes through it. So in this specific example on the screen, so the abdominal wall is over here where the big purple arrow is. Here's the spine, these are the muscles. And so this dark line here is your abdominal wall, and there's a hole where presumptively this is the intestine kind of protruding through that hole. Now, in most cases with a hernia, the contents, in this case intestine, kind of go through the hernia, they come back in, and that's what we would call a reducible hernia. So that's where most patients will present to the office. They'll notice a bulge on their abdominal wall, and it's easily, reducible, as we say, soft, goes away when they press on it, doesn't cause a lot of pain, and it's just kind of there. Most patients have these for a number of years. Generally speaking, they don't require emergent surgery, but they can have symptoms along the way that bring them to my office, of course. In terms of the other types of hernias, so this is, again, just kind of a broad characterization of all the hernia types that a surgeon like myself would see. So the most common that we see probably are the umbilical hernias. So this is basically right underneath your belly button. If you have your shirt off and you have kind of the outie, as they call them, odds are you probably have an umbilical hernia that you don't realize is there underneath. There are incisional hernias. So these are patients that have had previous surgery, and then basically the repair of the abdominal wall has in essence failed over time for whatever reason, and they develop a hernia at that site. There's an epigastric hernia, which is a fancy name for just a hernia in the abdominal wall that is above the belly button. Generally presents the same way an umbilical hernia would, has the same symptoms. It's just anatomically, we just classify them differently because of the location on the abdominal wall. Spigelian hernia is a little more rare. As you can see, it's off of the midline. So here, these are more rare because as our abdominal wall is constructed, it's usually stronger outside the midline, which is why most of the hernias you see are in the middle. Additionally, that's why we put incisions in the middle, because it's less tissue to go through. Also are repaired the same way as these other hernias. The other hernia on here is an inguinal hernia. So this hernia is technically through the abdominal wall. However, you generally will not see it on someone's abdomen. It's in the groin. This is also a very common hernia, especially in men. Somewhere around one in 4 to 1 in 5 men will develop an inguinal hernia over the course of their life. Obviously, most of them will go on to have surgery because they continue to get large and become symptomatic. This is just a slide kind of reiterating what I had just shown. Again, this is kind of the protuberance of the intestinal material through the abdominal wall. I think the biggest takeaway from an inguinal hernia in terms of classification is, like I mentioned before, this is going to be a hernia that you find near your groin, whereas a ventral hernia is really higher on the abdominal wall. So these are just some pictures for kind of everyone's sake, like I had mentioned. So you can see on the right side of the screen, this is a patient's abdomen here. This is where their umbilicus, or belly button, as we say. You can see it's clearly kind of the outie form. And then conceptually on the inside, in kind of a 3D view on the left side of the screen, this is how it would look. So just kind of orienting everyone. So the outside of the world is kind of this pink area here. This would be your skin. This would be what we call the subcutaneous fat. And then the hernia is right here. So you can see these are all the intestines, and they're coming through this opening, creating what we would call as a hernia, looking like this on the abdominal wall. And our hope as surgeons and for our patients is that this is something that's easily reducible, meaning that if you press on it, all this hernia content will then reduce back into the abdomen. And that is a safe hernia to have that does not need urgent repair, but likely should be evaluated by, either your primary care doctor or by referral to a surgeon. Our ventral incisional hernias. So essentially, there's a few ways to fix these. The older way is what we would call open repair. So the general way to approach this is a large incision over the midline. This is usually reserved for patients who have had previous surgery. The thought being that it's generally safest to approach an abdomen that has had previous surgery through an incision because it is perceived to be safer. However, over the last few years, Da Vinci surgery, which is also known as robotic assisted surgery, has become much more common. And there's a lot of growing literature to suggest that it's just as safe, if not better for patients than a traditional open approach. Laparoscopy is kind of the midway point in terms of advancement from open surgery to robotic surgery. You can see here these red dots that are on the two bodies to the right side. These are actually the incisions that we make in order to repair the hernias. So you can see there's a stark difference between the approach of an open hernia repair, being a large incision in the midline, to having just a few small incisions that are usually on the magnitude of 5 to 10 millimeters in size for each of these small red dots. Laparoscopy is efficacious. It's a good repair, but it may not be done by every surgeon because, like I had mentioned, it's kind of the intermediary of development between open surgery and robotic surgery. So I personally do not do laparoscopy repairs for hernias. I perform most of my hernia repairs through the use of the robotic technology. And if for some reason I can't do that, then open surgery becomes the default pathway for treatment. So how are they diagnosed? So there's a few different ways. I think that honestly, the most common way that hernias are diagnosed are actually by patients themselves. No one knows your body better than yourself. So generally patients will go to the doctor and they'll say, hey, I have kind of this bump that comes and goes throughout the day. I notice it gets bigger during the day when I'm at work. And the classic is that I notice when I lay down, it's gone. Essentially what that is when they lay down, gravity just spontaneously reduces that hernia for them. So that way they no longer appreciate it. Depending on how large the individual patient is, they may actually be able to feel the hernia defect themselves, and that will generally lead them to go see the doctor. Depending on what your primary care doctor or surgeon you're seeing is concerned about, they may order other tests. Ultrasound is very easy to do. Unfortunately, it's also very operator dependent. So sometimes it's not perfect. We see oftentimes that we'll have an ultrasound with a negative report for a hernia. However, on exam, it really seems suspicious that they might have a hernia, in which case we can move to a CAT scan or a CT scan, which most of the time, in conjunction with physical exam, will show a hernia if we believe there to be one. MRI is not used a lot for hernias. I would say this is not the standard approach for diagnosis. In my limited experience, it seems as though MRI usually they're incidental findings, so they're kind of found on accident on an MRI, while the MRI was originally planned to find other pathology. Some symptoms and some causes of hernias. So remember back when I mentioned that a hernia is essentially just a hole in the abdominal wall. So as we grow as people, and then as we go through life, you know, either working out, working a manual job, just being generally active, that frequent activity level can predispose you to developing a hernia, especially in men. And all it takes is a really small hole to start with that eventually can grow into a big hernia. If you've had any previous abdominal surgery of any kind, you are at risk of developing a hernia. Size of the incision is actually irrelevant because even we have found incisions as small as 8 millimeters, which is classically the size of a robotic incision, can still cause a small hernia, which can become symptomatic and require medical evaluation and potentially surgery depending on your symptoms. Any prior hernia, having a prior hernia predisposes you to have another hernia, potentially in a different location or even a recurrence after surgery. Chronic cough tends to potentially worsen existing hernias because every time we cough, we increase our intra-abdominal pressure, and that will put stress on the abdominal wall, increasing a risk for developing a larger hernia. Bowel injuries, so this is patients with diverticulitis or some other inherent bowel problem. They're an increased risk. And also pregnancy, this is more secondary due to just the growth of the uterus during pregnancy, stressing of the abdominal wall muscles, and generally most common hernia we see after pregnancy is an umbilical hernia that patients didn't know they had prior that then just get worse during their pregnancy. Some symptoms of hernia, the most common is the bulge. So most patients who have a hernia, their initial complaint in terms of accessing healthcare is through appearance. So cosmetics. So they have a bulge at their belly button, or they have some other, lump or bump that they've noticed kind of comes and goes throughout their life. Pain is probably the second complaint. However, if they're having pain, they usually present much earlier in terms of trying to seek cause and potential treatment. Heaviness or weakness, this I would generally reserve for patients who are larger, that have much larger hernias. They feel as though as the hernia grows, it kind of pulls their abdomen, to the left or right, depending on how their abdominal wall sits. Tenderness kind of just goes with pain. However, when I think of tenderness in the area, I think of just kind of a global, my abdomen hurts or my belly hurts in the right side versus this specific location. Nausea is actually a concerning finding if you have a hernia, because there's always the potential that the hernia is causing a hindrance to your body or your GI tract moving material through. So you end up getting a backup feeling. So you feel fuller quicker after a small meal that isn't normal for you. And you just kind of develop this nausea over time. And usually that ends up resulting in some vomiting and then a presentation to the emergency room. So I'm just going to talk a little bit about how we actually repair them. So my preferred way is a robotic assisted hernia repair. So this would be reserved for patients who come to the office as an elective case. So this generally is not performed on patients who present to the emergency room with acute complaints and require emergent surgical repair. However, this is a great tool for patients who just have a known hernia that they want to get fixed to either prevent symptoms from occurring in the future, or for the hernia to get bigger, or maybe you're having problems, performing your duties at your work, and then, you seek hernia repair. So essentially what this is a tool that surgeons use to fix a hernia. So you can see here on the right side of the screen, this is actually what I would do in the operating room. So every operating room where there's a robot, there's a console, which is what the gentleman in the picture is sitting at. And there's basically two joysticks that you can see here that his hands are attached to. What you can't see in the picture is off to the right side is where the patient is, with the anesthesiologist, the bedside nurse. And to start the case, I actually will place three small incisions, 3 trocars, which are basically tubes that allow me to put small instruments into the abdominal cavity and fix the hernia. This is essentially what it looks like on the inside. So this is one of the tools I use. So just to give you an idea of scale, the distance from this little circle here to the end of the instrument is about 2 centimeters, which is less than an inch. And then in terms of the anatomy you're seeing, this all in the background is the abdominal wall. This here is the midline here, and then this is the hernia, likely with what we would call incarcerated, which means you cannot reduce the hernia, or it's hard on the outside and painful. And then this is likely some incarcerated fat from what we call the preperitoneal space, which is just fat on the inside of the body that you don't see. So this is kind of the full equipment scope here. So this is the console on the right side that I sit at while fixing the hernias. This is the actual robotic machine here. So you can see there's 4 arms that I use. One arm will have a camera, and the other 3 arms basically have small tools for grasping, cutting, any cautery that I may need, as well as putting a specimen retrieval bag if there would need to be some kind of resection that would need to be performed. And then over here on the left side is really just the tower where basically the nuts and bolts and the computer of the whole system run. Okay. This here is just showing the access that we use for robotic hernia repairs. So the patient over here on the left side, so if you had a midline hernia that needed to be repaired robotically, you would have these 3 small incisions. Each of these incisions would be on the order of about 8 millimeters, so pretty small, usually about the width of your thumb. And then over on the right side, this is the port placement that we use to repair inguinal hernias. Again, very small incisions, the same exactly, just in a different orientation. Because on the left side, we look to the midline of the patient, and over on the right, we actually look into the pelvis where the inguinal hernia lives. For the robotic platform, in terms of benefits, so I believe that the robotic repair is the best repair that you can have. As the patient, it's known that because it's minimally invasive, you'll have less pain. The studies suggest that there's less scarring, specifically on the outside, because I had mentioned those small incisions that you'll have. This means that you have a shorter recovery time. So most patients who I do an inguinal hernia repair on, as an example, return to work. If they're not having a manual laborious job, they usually return to work in about a week, and they go home from the hospital same day. In terms of getting back to daily activities, everyone's different. It depends. There is a weightlifting restriction no matter the type of hernia repair that you have, of 6 weeks of no heavy lifting, which we technically quantify as no more than 10 pounds. And because of the small incisions, the surgical complication rate is much less. So that would include bleeding, surgical site infections, infections of the mesh that we use to repair the hernia to reinforce the abdominal wall, as well as damage to your other organs during the operation. In terms of the benefits for me as the surgeon, the tools that the robotic platform provides, to be honest, it's much more comfortable. The field of view in terms of the camera access on the robot is much magnified. There's much better detail. It's basically like operating in high definition TV. So seeing structures that are important to make sure patients stay safe and make sure I do a good job are much more obvious. And in terms of longevity of my career, it's much more ergonomic. And you know, it's easier on my hands. And I think that translates to a much more comfortable operation for me, which leads to better results for patients. Sometimes I get patients in the office, even though they're seeing a surgeon, who are a little apprehensive about surgery, kind of wondering if there's any non-operative steps that they can take. So there are, if I'm being honest, I don't think they're great options, especially if you're a younger, you know, healthy, fit patient that's going to lead an active life. Non-operative management of a hernia probably is not the best long-term solution. However, in the short term, you know, if you're going on a trip or you just have something going on in life that you can't have a surgery for, you know, and then go on a weightlifting restriction for 6 weeks, there's abdominal binders that can help reinforce the abdominal wall that you can wear. And there's also girdles, you know, like jock straps, if you have an inguinal hernia, that you can wear to help prevent the hernias from progressing. However, these are not really good long-term solutions. The right side here, this picture is just because the girdle here. So essentially this is just what the inside of the abdominal cavity would look like if there was an inguinal hernia. So that's this hole here, the midline of the patient's over here. And basically we would reduce this out and fix the hernia. So that's what the hope is, that excuse me, that's what this girdle would do over here. But again, it's not going to fix the hernia. It's not going to make it go away. It just might temporize the situation in the short term. And for those of you who are more, you know, evidence driven, so there are some early, albeit early, studies in the medical literature to suggest that, you know, patients who have a robotic approach, they go home from the hospital earlier, they're happier, they have less pain, you know, their life is not as disrupted from surgery. And honestly, it's becoming more of a lower risk, more straightforward procedure than hernia repair had been seen in the past, when we did much more open surgery and also even laparoscopic surgery. So it definitely is a step in the right direction. I firmly believe it's better for patients. This is another important thing. I think that we're all pretty knowledgeable about how pain medication affects people, especially in our society. And as physicians, we're probably to blame for that a little bit over the last few decades, but we've tried to right that. And, you know, I get a lot of patients that are worried that after they have surgery, they're going to become dependent on pain medication. And honestly, in terms of narcotic use for my patients, it's usually only in the first, you know, 48 to 72 hours, because that's where they're in the most discomfort. And I'm a firm believer that if you're in discomfort, you're not going to be getting up, you're not going to be eating, you're not going to be trying to get on the road to recovery. So we give narcotics for the first 48 to 72 hours. And then after that, just Tylenol and Motrin. And the vast majority of patients respond well to that plan. And even in the studies that we've seen, you know, upwards of, you know, 9 out of 10 people, that's the path they follow. There's always the chance that, you know, you're just one of those people who has less pain tolerance, or maybe just don't have a great outcome in terms of pain management, and you require more pain medication. But for the most part, most patients get away with pretty low need for strong pain medication outside of Tylenol and Motrin. Those are the slides I prepared. I kind of hope it might turn more into kind of question answer as best as I can. But yeah, thanks for listening to me. I found it.
Yeah.
Is it okay if I just start at the top?
For sure, go for it.
All right. So there's a question here. Told I needed a laparoscopic hiatal hernia repair with fundoplication, but my pulmonary doctor tested me for sleep apnea. If it comes back that I have sleep apnea, will I still need surgery? So I think first and foremost, what I hope I was able to convey that not every hernia requires surgery. However, in your specific case, if you're having symptoms secondary to a hiatal hernia, then yes, you should seek potential evaluation by a surgeon. Sleep apnea generally is not caused by a hiatal hernia, so it probably is two separate problems that you may be having. I hope that answers your question. Can you have, and someone else asks, can you have a hernia with no pain? Yes, you can. Frequently, at least on the inpatient side of the hospital, where I also do a lot of my work, a lot of times I'll get consulted from the emergency room on patients who come in with any complaint, chest pain, they fell, anything like that. And they'll get a CAT scan or a CT scan of their, abdomen and pelvis, and we'll find hernias. And then I go see the patient. They don't have any complaints in that area. They don't have any abdominal tenderness. They don't have any nausea. And it's really what we would call an incidental finding. So we essentially found it on accident. And those patients I would just see in the office kind of on their own time, just to discuss, red flag signs and symptoms to look for, how to make sure they know it's reducible by pushing it back in, and things like that. So yes, hernias can definitely exist without causing pain. Why are there gender different? Someone else had asked, why are there gender differences in type and frequencies of hernia? So that's actually a really good question. So the most common hernia for both genders, as far as I'm aware, believe it or not, is an inguinal hernia. However, females tend to have an increased chance to have what's called a femoral hernia, which I did not go over as an example. A femoral hernia is like a special type of inguinal hernia that is more common in females. Basically, as far as we understand it, is just that the musculature and the strength of the pelvic floor and the groin are just slightly different. And so that's why they're at a slightly increased risk. Men generally get inguinal hernias much more commonly compared to the other types of hernias, because as we are, growing as babies, that the actual canal that the hernia forms in is actually open, and it closes as we get older, usually by the age of 3. In terms of umbilical hernias, it's kind of the same. A lot of babies will have umbilical hernias that usually as surgeons, we just leave alone unless they persist past the age of 5. And then if they're really small, we generally don't even know they exist, and patients have them all through life, and they eventually just get bigger or symptomatic, and that's how they find their way in. I think another big contributor to potentially gender differences in hernias is obesity. Believe it or not, the more obese you have, the higher chance you are to have a hernia that's going to get worse. And potentially also because of obesity, you probably are unlikely to recognize you have one to begin with, which means that you're unlikely to recognize if it gets worse. And that tends more towards the men's side of things. Hopefully that answered your question. Someone else has recently had an open ventral hernia on the 15th, so just about a week and a half ago. They have a follow-up appointment tomorrow. They're still very sore. They're wearing an abdominal binder, which is a good idea. How much longer will the soreness be there, and how long is this wrap going to be part of my wardrobe? So I guess the easiest part to answer that is the abdominal binder. So it's my personal belief that the abdominal binder in the short-term post-operative period is important to help reinforce patients that they have a strong abdominal wall, as also give them some comfort that there's some other reinforcement, because a lot of times in the post-operative period, patients are concerned that they can injure the work that I've done. And I think that by wearing the abdominal binder, it provides an extra level of confidence. So you should wear it as long as you want. Some patients, they don't like it. They feel constricted. There's no hard and fast rule. As surgeons, we like them just because we believe, like I said, it provides the extra level of confidence for patients that they feel more comfortable. But by no means is it necessarily required long-term. In terms of your soreness, what I usually try to tell patients is after 2 weeks, you should be getting back to feeling pretty good. I think the expectation of being pain-free is probably an unrealistic expectation up until about the 2-week mark. I think being sore is very reasonable, but you should still be comfortable enough to, cook for yourself, move around, use the restroom, shower, things like that. Hopefully that's helpful. Any other, someone else had asked, any other causes of hernias? To be honest, there are many different causes of hernias, but I think that the main ones were what I had hit there. You know, frequent activity, obesity, previous surgery is extremely common, and it doesn't matter what kind of surgery it is. Did anyone? Sorry, there was the mentions repair after surgery. Does this mean removal? Like I said, I think that was probably in relation to the incisional hernia repair, because by definition, those come after surgery. So, you know, to be blunt, if I do an open operation, there's a chance they have a hernia after surgery that I caused, essentially. But that's just kind of a normal risk of having surgery. So we don't necessarily remove anything. I hope that somewhat answers your question. Someone else had asked, does a hiatal hernia cause shortness of breath? So just to clarify for everyone, so a hiatal hernia, which I did not go over, is a special type of hernia that's actually on the inside. So you can't see it on the outside. So it doesn't present with a bulge. It generally presents with non-specific complaints, and then we find it. So shortness of breath, yes, could be one of them. Generally, shortness of breath is reserved for a large hiatal hernia. So basically what happens is the hiatus is the area of our body that separates the chest cavity from the abdominal cavity. So the diaphragm sits right there. And through the diaphragm, 3 structures go through. So one of them is our esophagus to get down to the stomach. That right there is the hiatus where the stomach can, what we say, herniate up into the chest. There are a few different types that I won't get down into the details, but yes, a hiatal hernia can cause shortness of breath, depending on the size. The more common complaint for hiatal hernias is reflux-related symptoms, burning of the esophagus, coughing when laying down, you know, things like that. I hope that answered your question as well. Someone else wants me to talk more about mesh. Yeah, so essentially, if you see a surgeon in the office and they recommend that you undergo what we would call an elective hernia repair, which means we schedule a day, you go in, we do a robotic repair or even open, you should have a mesh placed to help repair the hernia. So mesh is essentially the standard of care to, number 1, prevent recurrence. It has the best recurrence rate. Number 2, it reinforces the abdominal wall. And it really is the standard of care. Everyone should get a mesh for an elective hernia repair. However, if you're a patient who had to go to the emergency room for acute abdominal pain and they found that you had a problem at the hernia, sometimes we don't use mesh because we're concerned about potential infection from whatever other problem is going on. Unfortunately, if we don't use mesh, the risk of recurrence is much higher, and you probably will require another surgery after that. I hope that kind of shed some light on that for you. Someone else had asked, how do you prevent a hernia? That's a great question. I think first and foremost, trying to be as healthy as you can. So have a normal-ish weight, you know, try and be fit, eat a healthy diet, don't smoke, try to control your diabetes if you have it. I think all those things go really far away. I think those really go far to try and prevent developing a hernia. How does someone know when it's time? That is a great question that I get pretty much every time I see a patient in office. So I think it really is up to you. So as a surgeon, you know, it's kind of my job to have this shared decision-making model, you know, in terms of when it's time. I think if you're an older individual who has had a hernia for many years and you're really well-versed with the way it should feel, look on your body, and all those things, I think you could put it off. If you're a young person and you lead a really active life and you're concerned it's going to get bigger or limit your ability to enjoy the activities, whether you're young or old, that's when it's time. As soon as a hernia starts to inhibit your ability to enjoy your life, it's worth having a conversation about getting it fixed. Someone else had asked, what's the best way to prevent hernia? Okay, we kind of already answered that. And then they had asked, is there a genetic component? Honestly, I do not believe there is a genetic component to developing hernias in the abdominal wall fashion. You could argue that there potentially is a genetic component in developing something like a hiatal hernia, because that usually is due to anatomic differences, potentially. Someone else has a long question. So somebody says, hello, they have two hernias. So one ventral, so remember that's just an abdominal wall hernia, and one peristomal hernia. So just so everyone is aware, so a peristomal hernia is a hernia that occurs to somebody after they've had a specific abdominal surgery where they have a colostomy or an ileostomy or an ileal conduit for bladder drainage or something like that. So it's not a very common one at all, and it's always after someone has surgery. They both involve fat, no intestines, but are both very painful and limiting. I'm told surgery isn't feasible because of the stoma I have. So other than weight loss, what are the viable options for relief? That's a tough one. Obviously there's not much other context, and I don't know you specifically, but my first thought as a surgeon is to get a second opinion. I think that most people, if you're having a problem that is inhibiting your quality of life, it is worth seeking out another opinion from a qualified surgeon who does these operations to see if they think it's worthwhile to try. And because, all surgeons are different, all of us perceive risk differently, and all patients also perceive risk differently. And even though you're potentially high risk, it still may be worth it for you to undergo surgery, because if you're having that much discomfort and pain, it's probably inhibiting your daily life. And at some point, maybe the risk of surgery, despite it being high risk, is worth it for you. So I think if you're not getting a good, answer from your surgeon, potentially seeing a second surgeon that specializes with a peristomal hernia repair might be in your best interest. Someone else, yes, I do use mesh for all of my elective hernia repairs, whether it's a ventral hernia, umbilical hernia, inguinal hernia, incisional hernias. Everyone gets mesh unless, like I mentioned, there's a reason not to, which is usually something like they have an abdominal infection or some other reason to preclude the use of mesh. Everyone gets mesh. Should someone with a small hernia have surgery right away or wait until it gets larger or painful? I think that a couple of things. First of all, it really depends on the type of person you are. So what I usually tell patients is, if you're the type of person that's going to worry about it and perseverate over it, and it's going to cause you anxiety and distress, just get it fixed. That's my personal opinion. If you have one, you have the indication for surgery. And that's just a conversation with the surgeon about the risks, and then it's kind of up to you to decide. However, some people, they don't mind that they have one. It doesn't cause them a lot of symptoms, and they wait. I also see a lot of patients like that who aren't very keen on having surgery. Usually those are patients who have never had surgery, so the prospect of having surgery is, a little anxiety driven, which I completely understand. And so they elect to wait. It really comes down to what type of person you are and what you want for yourself, to be honest. What physical exercises can be done to prevent common hernias? I don't think there's any specific exercises. Honestly, I really think it's just whole body, being healthy, nutrition, getting some, exercise in, whether it's running, weightlifting, just trying to be the best healthy, strong person you can be. And I know it's tough, especially if you're older and you have some mobility issues, but even, starting small, and, you can end up pretty far over the course of time if you keep working at it. But there's not really any specific physical exercises, as far as I'm aware, that have been proven to help prevent common hernias. Someone asked, how often does a hernia mesh fail? That's a great question. So the stat that we usually tell patients as surgeons is a broad-based 5% chance of recurrence. Generally speaking, that 5% chance of recurrence comes from a couple of things that add together. Number one is the mesh itself. So it's a synthetic mesh. It's made by a company. It's going to have a failure rate just like any other made thing in the world, right? The second thing is your individual characteristics as a patient. So patients who are at a higher risk of mesh failure are obese patients. So anyone with a BMI greater than 30, who aren't big strapping bodybuilders, as an example, they're at a higher risk for recurrence. Patients who smoke are at a much higher risk for recurrence, and patients who have poorly controlled diabetes are kind of the classic examples of patients that we have seen in the literature have a higher mesh failure rate. And yes, if the hernia repair with mesh fails and you then have another hernia, generally speaking, yes, you would need additional surgery to repair it, which is why, again, it's kind of up to the surgeon to help guide you to try to minimize that risk before doing that first operation, because every operation after that first one is just a little bit tougher and comes with a little bit more risk. So thanks for that question. Hopefully that was helpful. Someone else asked, when should a hiatal hernia be fixed if there are adverse symptoms? I think any hernia and surgery, no matter what the type is, should be fixed once it's causing you enough symptoms to inhibit your quality of life. I think that's a straightforward rule. Before that, if you want it fixed because of whatever reason you have, that's a perfect time to have a conversation with your primary care doctor, to be referred to a surgeon, just to even have the conversation. Is there a medical condition that causes a bulge, posing like an inguinal hernia, but is actually something else? That's a good question, yes. So there is, off the top of my head, you can have what's called a varicocele. So basically, in men specifically, that canal I mentioned where the inguinal hernia forms is where also our blood supply to the testicles go, as well as what carries sperm up and down. So there, within that complex, there's also a bunch of veins which return blood back to the body. Those can kind of get engorged and cause a bulge, as an example. That's just one thing that can cause. Other things that can happen is you can get other fluid collections kind of in the area, because it is a space, and our body does a really good job, it seems, of just throwing fluid at body cavities. So to answer your question, yes, which is why in concert with physical exam, imaging is usually the best thing to go about it, because I have seen on exam before where I think someone has a hernia, but then I get an ultrasound and there's nothing, and a CAT scan, there's nothing. Or I find a completely other pathology. So yes, there is something else that can kind of masquerade as an inguinal hernia. That's a good question. The success rate after an umbilical hernia surgery or recurrence rate. So I just mentioned that recurrence rate kind of flat across the board is about 5%. Umbilical hernias generally are smaller, so their outcomes are better. If you were going to put them on a spectrum, they're smaller, they're usually not symptomatic, and they're usually easier to fix, to be honest. So they usually have better outcomes as a whole. Someone says when they bend, they feel like a piece of tissue jumps over their ribs. Is this a hernia or maybe a muscle? If it's in the midline, so right, kind of in the line above your belly button, potentially hernia. If it's off to the side, it probably is not a hernia unless you've had previous surgery there. Could be a hernia, but I think it's pretty low percentage chance that it would be. Commonly, it could be a muscle or even something like lipoma, which is just a collection of fat kind of outside the abdominal wall, just in that location. But without seeing it in person or seeing imaging, it's really hard to tell. Someone has a hernia in need of repair because of pain, sometimes doesn't go in softly. I was told they will not operate on it until I lose more weight. If there's anything I could do until I lose the requested weight to stop all the pain, it's taken over my life. I weigh 310 pounds. I did have surgery twice for the same. Um, that's a tough spot, I'll be honest. So that generally is the recommendation we give patients. However, again, without knowing a ton more about you specifically, I would say that's generally the recommendation, yes, especially if you've had 2 hernia failures already. Really trying to lose weight is your best option. However, every patient is different. And, I'm a firm believer that if this is really inhibiting your life, it's hard to lose weight if you can't exercise because you're in pain. I really get it. That's just another conversation to have, about risk and going through another surgery. And, odds are, without losing weight, if you have surgery another time, it probably will fail again, to be honest with you. But glad to talk more about that offline. Are double inguinal hernias common in men? So I think he may be referring to having one on each side. So what we call bilateral inguinal hernias, and yes, they are. Frequently, I'll find if a patient comes to the office for a right-sided inguinal hernia and we go to the operating room, I frequently will find one on the left side once I start operating. So yes, they are common. I was told that since I have had robotic removal of my prostate, I would not qualify robotic repair of my hernia. Is this true? No, it is not. I would gladly talk to you in my office. That is an old recommendation that is coming to not be true. It just means it's much harder and has a higher chance for us not to be able to do it. But generally, most skilled surgeons on the robot will at least attempt it. Are there any exercises strengthening the abdominal wall area? Yes, these are easily, Googleable. You can use that verb. So, anything that is core, yoga, crunches, any, weightlifting routine that involves abdominal muscles would all work. Someone else asked if there was a BMI requirement. I was told I need to get to 35 and I'm about 42. Hernia has become large. I'm having symptoms, sometimes severe pain and nausea. There is no BMI requirement. Like I had mentioned above, it really just comes down to conversation between you and your surgeon about acceptable surgical risk and what your symptoms are and how life-limiting they are and what your actual attempts to true weight loss have been. There is no minimum requirement for weight. Someone else has bilateral inguinal hernias, but they're not bulging and there is no pain. Should I get these surgically repaired or should I just watch them? I think I've answered that a few times. If they're bothering you or just the fact that you have them bothers you, come see me and we can have a conversation or, about getting it repaired. Do all hernias require mesh? Is the Schuldeis method still used? So in my personal opinion, all hernias should use mesh. Schuldeis is for those of you who don't know, is an old, what we call tissue repair method, which I personally would not do and I would not recommend anyone have because there are known to be better repairs, which is the mesh repair, also known as a tension-free Lichtenstein mesh repair. I have had 2 hernia surgery repairs. I have a lot of mesh, however, they've come back. So this patient has had surgery, now has an ileostomy, has since been reversed. You're very distended. What can I do next? Very hard to answer that question in this forum. But again, I'd be glad to talk about it. Or, like I said, go back to your surgeon and discuss your symptoms. And my guess is it'll start with a contrast CT scan. Someone else asked, can you have a hernia does not have an external bulge? Yes, of course you can. Yes, you definitely can have those symptoms and have a hernia that doesn't show it. Doctor ordered an ultrasound, but said that based on location, very hard to see it. That is true. Again, ultrasound is not great. My personal practice, if I think someone has a hernia based on symptoms, it's hard to appreciate on exam and an ultrasound doesn't show anything. Next step is a CT scan. If the CT scan is negative, you probably don't have a hernia. Because again, physical exam not showing one, ultrasound not showing one, and a CT scan not showing one, odds are you don't have one. Someone had a previous surgery repair that has now failed, it seems like, and they have a larger one. What are my risks to have surgery done again and have the mesh removed? I think the risks of having another surgery are the same as the previous one, but you might be at a slightly higher risk for complications of that just because you've had surgery before. But like I said, if it's inhibiting your quality of life, you should definitely seek out, an appointment to have that conversation. Someone else asked, how do I repair the hole that caused the hernia? So basically what I do is I reduce all the contents. I then put a mesh in underneath the hernia. And then I close the hernia with suture, basically, to restore the abdominal wall back to its native anatomy. It's frequency of problems with mesh. So this is a good question. Hard to answer in this forum because I think there's a lot of conflicting data on it. However, things like mesh failure, which I've already mentioned, there's also mesh infections, which are probably the most devastating because those meshes need to be removed surgically. That also is a very low risk, specifically with the robotic platform because of how small the incisions are. And those usually come from having other issues during surgery, like bowel injuries or things like that. And there's also the concern for mesh migration, which is movement of mesh, which we try to, as surgeons, avoid by suturing the mesh in place. So I would say that the frequency of those problems are relatively rare, assuming that it's a good quality repair. And what I mean by that is that as a surgeon, I had good tissue to sew to, and patients are not, diabetic, they're not heavy smokers, and they are, of appropriate body weight. How large can an inguinal hernia get? They can get extremely large, and they are never too large to repair. Can you explain the risk of strangulation? So strangulation is basically when you have that hernia that you can't reduce or you can't push back in. Generally, they get hard, they're tender, maybe the skin gets angry. If this is untreated, patients go to the emergency room and I do surgery that day, that night, whenever it is. The type of hernia that's greatest risk for that is likely an incisional hernia. The difference between a hernia and prolapse. Oh, great question. So a prolapse is basically where the entire abdominal, so you asked specifically about pelvic prolapse. The difference is that a hernia is a small hole, so a non-anatomic, usually non-anatomic hole that something is protruding through. Prolapse, the whole anatomy moves, essentially. So usually we think about in rectal prolapse. So there's no new hole. It's just that the musculature of the pelvis has weakened, that when patients have bowel movements, the pelvic floor fails and they get rectal prolapse. So they're very different problems. When should I seek advice on a hernia? I think we went over that. Yes, robotic surgery is performed under general anesthesia. Yes, unless you are very, very high surgical risk. But again, that's very rare. No, colonoscopy should not affect your hernia. I also do colonoscopies if you're interested in that as well. Robotic surgery is an option after colon surgery. Yes, 100%. Are there any risks to not getting an umbilical hernia repaired? Just the progression of it, potential complications like the incarceration or strangulated hernia, as I just mentioned. Why did I specialize in hernia repair? It's really just nice. Every case is different. They're challenging, but yet technically simple. And generally, they have a pretty good impact on patients' quality of life once it gets fixed. That's usually why I like it. What kind of material is the mesh made of? Is it possible for the body to reject it? And how often does it cause irritation within patients? I have never heard of someone's body rejecting it. I don't know specifically what they are made of. And I believe every company has a different formulation. Someone else had a CT scan that just incidentally found a hernia. PCP says it's not to do surgery because it's not bothering them, but they feel pinching after lifting. I'd recommend just seeing a surgeon and talking about your symptoms and seeing if it's seeing if surgery is warranted. And yes, of course, I use mesh. Yes, you may request an ultrasound in addition to physical exam. And like I mentioned, if I'm not confident that you have a hernia in physical exam, I generally start with an ultrasound. Recurrence rate of robotic surgery is about 5%. just like every other repair. When can you go back to sit-ups after surgery? About 6 weeks. My 99-year-old mother-in-law requires around-the-clock care due to her mobility and has an inguinal hernia. She has flare-ups multiple times a week, causing her discomfort for hours, and it's often severe. She's tried a variety of remedies, takes some over-the-counter pain medications, does not tolerate stronger pain meds. Is there a role for surgery in someone like her? That's really tough. Without knowing anything else, she is not a great surgical candidate based on her age. She's immobile. And the last thing we want to do as surgeons is effectively hurt people. Every surgery has risk, and I'd really hate to have a negative impact on her life. But again, talk to your surgeon, talk about the quality of life issues and things like that. And every surgeon's different, is I guess one way better. Can you have a hernia in the bowel area? Yes, you can, but this is only after patients who have had surgery, and that's called an internal hernia. So if you've had a Roux-en-Y gastric bypass or something like that, you're one of those people that potentially could have one. Someone says they have 3 inguinal hernias scheduled for surgery today. I forgot to ask this question. I sleep without pain, but soon after I'm up, the pain kicks in. Why does this happen, and what can I do to prevent or minimize? My guess is that while you're sleeping, the hernia is reduced, and then as soon as you get up, the hernia becomes symptomatic because you're moving around, and then the hernia has a protuberance again. That's my guess. But other than that, good luck in your surgery. How is the screening attached with robotic surgery? I suture it in place, believe it or not. In general, what is the length of an umbilical hernia surgery? If I do it robotically, around an hour to 90 minutes. So pretty short in the surgery world. Someone else asks, how do I normally repair a hernia? Do I push it back in and repair the abdominal wall? Yes, exactly. A lot of these questions now are just about, do I use mesh? Yes, I do. Someone else again is asking about having surgery despite not having symptoms. Again, you should consider surgery, or at least having a conversation about it. When repaired, is the bulge completely removed and I can then resume exercise? Yes, the bulge should go away after repair, and you can resume exercise after 6 weeks. Someone else says they went to the ER for abdominal pain that was becoming unbearable. CT showed bilateral inguinal hernias. They then sent me home and said they don't do hernia surgery anymore. He said take Tylenol. Interesting. There may be some miscommunication in that, because I'm pretty sure Medicare does cover elective hernia repairs, but you'd have to check with them. In terms of symptoms relief, you can wear like the girdle I showed in the slideshow, like a garter. And also, in addition to taking Tylenol every day, you can also take some Motrin for pain as well, assuming you don't have any pre-existing kidney disease or intolerance to NSAIDs. How many inguinal surgeries have you performed? So hernia surgery is extremely common in general surgery training. I've been between training and attending practice, we're looking at 8 years now. So well over 100 in total on the robotic platform. Is robotic surgery okay for umbilical hernias? Yes, it is. If a hernia is small and does not inhibit your lifestyle, can you leave it alone? Yes, you sure can. Mesh has been the subject of massive lawsuits. Why still use mesh? Because mesh is still the best repair. I can't comment on the legitimacy of massive class action lawsuits, to be honest. I just genuinely don't know the details about them, and I'm not a lawyer. There's a lot of questions. What is the infection rate or risk with the mesh? So the infection rate is extremely low with robotic surgery, approaching less than 1%. Open surgery, it's a little bit higher because of the size of the incision. What is the mesh made of? I apologize, I'm not sure. Every company has a different thing. Patient's husband has a hernia that's into his scrotum. What questions to ask? Number one, ask if they do it robotically. If they only tell you they can only do it open, you should not have an open surgery unless there's some compelling reason. And you should also ask what type of repair they do in terms of using mesh or not, and they should use mesh. Is weightlifting worsen a hernia? Yes, it can. Does an inguinal hernia repair cause sterilization? No, it should not. Doctor told me I had to lose 50 pounds before you would schedule my surgery. I'm down 74 since Thanksgiving. Congratulations, that's incredible. And yeah, it can be done. Good luck. Somebody has had 4 previous inguinal hernias, 2 on each side, now have recurrence. The risk now is just that you're going to be an increased risk for perioperative complications. So again, mesh failure, bleeding, damage to other tissues. It's really tough to go back into an operative field due to scar tissue that forms. How do we contact you for a consultation? So I believe that in the information that you have, there is a phone number for the office. That phone number is 734-655-2692. Thanks for doing this, no problem. Happy to. And then last question, believe it or not, is do you operate on infants and children, and how is it different? So I do not operate on infants anymore, largely because that's specifically pediatric surgery, which is its whole discipline. I did during residency, but as an attending, that's not something I do anymore. In terms of children, I will operate on teenagers who are adult sized, but smaller than that, honestly, should pretty much universally be seen by a pediatric surgeon. How is it different? Honestly, the technique and types of repair that they offer to children and infants is different. We don't use mesh in infants. We don't use mesh in small children because generally they're very small hernias, and as they grow, they'll go away. Or if we just repair it with suture, generally speaking, it goes away because they're so small, and as they grow, their abdominal wall gets stronger and the repair will hold. Additionally, everything is so much smaller. So unless you're really used to working in that type of operative field, the risk of complications can go up. So how do you prevent hernias?
Go ahead.
What's that?
I was just going to say, I think you're just about to the end, but one dropped right in there as I was saying that. So.
Oh, okay. I think I got everyone's question, I hope.
Yeah, that was like a marathon. I'm very.
I apologize if it felt like I was reading the whole time.
No, it was fantastic. You touched a lot of questions, a lot of subjects. So I think you did a fantastic job. For those of you who are still hanging on, yes, you will receive contact information for all of the general surgery practices, including Dr. Payne's, which is in Livonia, correct?
Yep.
Okay. And we will include that. You can absolutely call. He shared the phone number. You will receive it in email as well. You can always visit ihcares.com and you can access our general surgeons that way as well. So thank you so much to everyone who attended. Thank you for all the great questions. It was a fantastic discussion. Thank you, Dr. Payne. That was a lot of effort there in the questions, and we appreciate the presentation and your expertise.
Yeah, of course. Anytime.
All right. Sounds good. Thank you all. Have a good evening.
Everyone have a good night.
Bye-bye.
See you soon.